Hello, everyone, and welcome to the March 2015 Cardio Learning Action Network, or the Cardio LAN meeting. We'd like to thank all of you for taking the time out of your schedule today to join us, and we hope that you'll find the content that's going to be discussed and presented on today's webinar helpful not only to your private practices and your clinical practices, but also hopefully to your own personal life as well. With us on the line today, we're very pleased to have Dr. Jean McSweeney, which we will introduce formally a little later in the call. We also have the 3RM project coordinators from HHQI, Misty Kevich, Crystal Welch, and myself, I'm Cindy Sun. We also have the health data analyst, Stacy Deslick, who will be along in a little bit to talk about the cardiovascular data registry and all the updates going on with that. And hosting all the webinar today will be Misty Dyke, our communication specialist. So at this time, I'd like to just remind everyone that all the lines are currently muted, and we'll unmute the lines a little later for those of you who are participating using your phone so you can answer or ask questions. And for those of you who are listening through your computer speakers, if you'd like to use the chat or the Q&A feature and the screen on the right-hand side, we welcome you to do that. We'll pause for questions after Dr. McSweeney's presentation, and then we'll also pause towards the end of the webinar today, time permitting, of course. So make sure that you get your questions in because we want you to have this opportunity. Dr. McSweeney is a very popular speaker, and this is the one opportunity. We are thrilled to have her here today, and we want you to have that opportunity to converse with her and ask questions if you do have them. So we'll go ahead and get things started, and I want to just point out that the very first thing we're going to do is have a quick polling question for those of you that are accessing the webinar through your computer, and we want to encourage you to answer this because it does give us a lot of feedback and lets us know where you stand in the innovation and the improvement of cardiovascular care in your agency. So if we'll go ahead to the next slide, and it shows us the cardio milestones, and this is what it's asking. Which cardio milestone is your agency currently at? If you are not a home health agency, you can still mark milestone 1 because you are part of the Cardiovascular Learning Action Network because you're on this call today. So while you're going ahead and completing that, I'll go ahead and turn the call over to Crystal Welch. Crystal?
For today's presentation, but we also are very excited that HHQI University has launched, and we now have 3 courses available for free nursing CEs and a certificate of attendance for all other disciplines. And the sessions are designed for the home health setting, but clinicians from any setting would find the evidence-based information useful. We have the first, briefly, just the state of cardiovascular health. It was our first release in January. This is just an overview of the cardiovascular health, and there are 2 podcasts, 2 nursing therapy tracks to read, an evaluation and post-test for a total of 1 continuing education hour. And these continuing education, or CEs, have been approved by ANCC for nursing. And some states do allow social workers to use those CEs, but if it's not approved in their state, agencies can certainly use the information for their own staff development educational sessions. The second is blood pressure control and smoking cessation. It's a little longer. It's 1.5 CEs, and it's geared toward clinicians in the form of nurses, therapists, or social workers. But there's a leadership section as well as a section for nurses' age. You get 1.5 contact hours for that as well. And then our last one we just released on March 2nd was tobacco effects and cessation medications. We added this 3rd online educational course, like I said, just on March 2nd, and this looks at the pathophysiology of tobacco smoke and the cardiovascular system. Additionally, a detailed look at 3 different cessation medications. Nurses who successfully complete this course will receive 1.0 free nursing CEs, and others completing the course will receive a certificate of completion. Just one quick brief thing, just each month we will be adding CE sessions to HHQI University. Most of the sessions have CEs, but not all of them. And just note that all webinars, such as the one we're listening to today, do not include CEs. So I just wanted to clarify really quick what webinars and what the difference between webinars and HHQI University is, because sometimes webinars registers courses in our mind. So just wanted wanted to make that clarification. Lastly, the upcoming eLearn posting will be Lifestyle Management of Cardiovascular Health. That's for 1.0 CEs, and that is going to be released April 1st. This course will include materials from the upcoming video BPIP. This is a new format for us here at HHQI, and we're very excited about this new type of best practice intervention package, or BPIP. And the Lifestyle Management Video BPIP includes 3 different short professional videos. The first one is Risk and Signs of Heart Attack and Stroke. This is a patient video. The second one is Lifestyle Management Part 1. It has to do with weight reduction, the DASH diet, and sodium reduction. It is a clinician-based video. And lastly, Lifestyle Management Part 2, physical activity, alcohol moderation, and smoking cessation. This is also a clinician video. So with that, I will wrap up, and I think we have another polling question or the results coming up. Otherwise, I will turn it over to Stacy Deslich. Oh, here we go. I'm sorry, the results for the question, we have where along the road for the cardiovascular health. So it looks like most of us have reached milestone 1, 61%, 19% at milestone 2, and 16% at milestone 3. So with that, I will turn it over to Stacy Deslich.
Alrighty, thank you so much, Crystal. Okay, to start off my little portion of our call, there will be another quick polling question to get everybody thinking about the Home Health Cardiovascular Data Registry. It's just, has your agency entered data into the Home Health Cardiovascular Data Registry, the HHCDR? There's yes, no, and no, but planning to this month. Or we are not a CMS reporting HHA and do not have access to the HHCDR. So we recognize that there are people on this call who aren't agencies but do play such an important role in cardiovascular health, in home health, or just in the medical field in general. So we like to include everybody. So if you want to go ahead and make your selection there, and I will move on to the HHCDR news and information. So the registry closed as usual on the 14th, and new data was made available on the 15th of this month. This is it's a monthly thing, so it will always close on the 14th. New data is always available on the 15th. Those of you who closed out your months prior to the 14th can expect your data to be reflected in the reports, which are now in production, to be available right around the 23rd, along with all the other HHQI data reports. Now, like last month, measure performance rates continue to hold steady. You know, it really might be a little while before we can see any trends in the data. It's a slow, steady process, but it will allow you to use your data to positively impact the cardiovascular health of your patient populations. Sometimes this is the hardest part for me, anyhow, is being patient and letting the data, the story fold out that the data is telling us. And it will take some time, but keep at it. So the most abstracted measure by far is the tobacco measure, and that's followed closely by hypertension control and aspirin as appropriate, which are nearly equally abstracted. The cholesterol measures continue to bring up the rear, but they are being increasingly selected for abstraction, which is great to see. It's awesome that there are so many people who are starting to select that cholesterol measure. So now for my favorite part, the congratulations bullet of the slide. First, there are several agencies, and really more than I can name here on our webinar, but they've closed out 6 months of data. While I don't have time to publicly recognize you on the call, let it be known that your success has not gone unnoticed, and in fact, it created quite a happy dance here at HHQI. So, awesome work. And additionally, there are agencies that have abstracted all the measures for all the months. So a great big hooray for you. This is excellent. I can't tell you how awesome it is to see such participation in the registry. And finally, we would like to recognize Winneshiek County Public Health from Iowa for being the first agency to close out their data last month. This is awesome. Now everybody understand that this agency beat out several others by mere minutes or hours. We have some real go-getters out there, and often we have several agencies fully abstracted and closed within 24 to 48 hours of opening the registry each month. This tells me a couple of things. First, home health agencies are a very motivated group, and they work hard to improve cardiovascular health in their communities. And second, abstracting data for the registry is a very achievable goal. So please don't be intimidated or feel overwhelmed by the registry. I know it's new, but HHQI is here to help you work through any bumps you may come along. So just take it one step at a time. Start with 1 month, one measure, and grow from there. And remember, HHQI is always here to help. Your success is so important to us, and we want to help you reach your goals. So in that vein, this month's Cardiovascular Data Registry Challenge goes out to those agencies in the cardio land that haven't abstracted any data. Go ahead and give it a try. Just one measure, 1 month. Let us know if you need help. You can email us at hhqi@wvmi.org or just click on the Contact Us tab on the HHQ website. So with that, it looks like our polling question has ended, and 22% have entered data into the registry. Yay! 29% haven't, so there's your challenge. Go ahead and enter it. 9% are planning to this month, so great. And 36% of us are not CMS reporting agencies, but continue to understand the importance of your role that you play in cardiovascular health. Now with that, I will pass it along to Cindy so she can introduce our speaker for this month's webinar. Cindy?
Thanks, Stacy. And I will just say before I introduce Dr. McSweeney that I had the privilege of speaking to those at Winneshiek in Iowa. The home health agency recognized as the first to close this month. And I will tell you that they closed 3 measures and they were the first to close this month. So on top of being the first to close just 1 measure, they closed all 3, they closed 3 different measures. So we want to definitely send out special thanks to them and to all of you, as Stacy said, who are participating in the registry, especially to those of you that have completed all the months and all of the data. We'll talk about validation in the next cardio land meeting, but that is the next step and the next milestone that you are coming upon, so we can talk about that and work through that process if you're interested in it. All right, so today's guest speaker, I'm very pleased to introduce Dr. Jean McSweeney. As you can see on the screen, she has multiple professional organizations in her official title. And Dr. Jean McSweeney is a research pioneer in the field of women's cardiovascular disease and published for the first study that described women's symptoms of heart disease. Findings from her initial study about women's early warning and acute symptoms of heart disease across ethnic groups received national and international coverage from television and radio stations such as CNN and CBS Evening News, and newspapers such as the New York Times and Chicago Tribune. She has presented her research findings at the National Heart Attack Alert Coordinating Board, served as a discussant for the National Heart, Lung, and Blood Institute's Women's Ischemia Task Force, and was a featured speaker at the National Institute of Nursing Research's 20th Anniversary Symposium. She has received funding for her research endeavors from the National Institute of Nursing Research, American Heart Association, Sigma Theta Tau International, and the American Nurses Foundation. She has received continuous funding since 1999 from the National Institute of Nursing Research. She has published in numerous nursing and medical journals, including Circulation, the premier cardiovascular medical journal. Her research on women's symptoms of heart disease also have been featured in a variety of women's magazines and news journals such as Ladies' Home Journal, Family Circle, Prevention, and U.S. News and World Report. Her achievements demonstrate significant contributions to nursing research, healthcare, and health policy to optimize women's health. Dr. McSweeney is also the director of National Institute of Health-funded Center for Biobehavioral Interventions and teaches the doctoral nursing program at the University of Arkansas for Medical Sciences. In these roles, she assists in developing the current and next generation of nurse researchers. Dr. McSweeney is the recipient of the 2004 American Heart Association Manuscript of the Year Award and the 2005 University of Arkansas for Medical Sciences Chancellor's University Graduate Teaching Award, and in 2005, American Heart Association's Best Abstract Award, and finally in 2007, Southern Nursing Research Society Leadership in Research Award. She is also recognized as a distinguished alumni of the University of Texas at Austin School of Nursing. You can see why it gives us such great pleasure today to introduce you to your guest speaker, Dr. Jean McSweeney. Dr. McSweeney?
Thank you, Cindy. It's my pleasure to be here today, and I'm hoping that you will all learn something about how to take care of yourselves and also about how to help other women. And it's always my joy to talk about women and heart disease since I've been researching it for over 20 years now. And I'm going to talk today specifically about recognizing risks in women that makes them more likely to develop coronary heart disease. I want to start off just with some key facts about cardiovascular disease, and as you are all aware, coronary heart disease is one of the types of cardiovascular disease. We often think about this as being a disease that's primarily in the United States, but indeed it is a huge global issue. I presented over in Sweden a couple of years ago and got into the statistics for World Health. And I really was amazed at what a large issue this is, not only for women in the United States, but for women across the world. In just 2008, you can see 17.5 million people died from cardiovascular disease, and it accounts for over 31% of global deaths. And in the United States, just with the coronary heart disease, it accounted for 7.4 million deaths. But by 2030, look at this, almost 23.3 million people will die from cardiovascular disease. And the economic impact, especially in developing countries, is huge because women in developing countries tend to have cardiovascular disease at an earlier age. They're oftentimes disabled, and it pulls them out of the workforce and unable to care for their family. So this is a huge worldwide issue. In the United States, the mortality trends are looking better for both men and women. When I started doing research, it was around 1993 when I initially started doing research with women and heart disease. And you can see in the red line that women's mortality rates were increasing at a very substantial rate at that time, and we were very concerned. Men's rates were dropping, women's rates continued to elevate. And it wasn't until we began to get some of our studies that appeared in the literature, because it takes a while for our studies to be conducted, to analyze the data, and then to get them published. And it wasn't until we started publishing some studies specifically on women that you began to see some of the decline, which started right after the year 2000. And it is now dropping significantly, and we are hoping that women and men's rates are going to be the same, and women will no longer exceed that of men. And we've got a good start towards that. If you look at the prevalence of cardiovascular disease in adults greater than 20 years of age, and this is from the NHANES data, you can see the difference between men and women's prevalence rates. And it's really not until women enter older age, 80 plus, that the prevalence begins to exceed that of men's. The incidence of MI, however, does vary by age, sex, and race. And if you look at these, the red is Black or African American men, and you can see they have the highest rates of MI or some kind of a fatal episode, and that usually is an MI compared with the other age groups and races. And again, you can see as regardless of the race or of the sex, as one ages, one becomes more likely to experience a fatal event. Sorry, my clicker's not working as well as I would like it to. Cardiovascular disease is the leading cause of death in females, and I will put this slide in here because we have a tendency to think of breast cancer as one of the leading causes of death in women. However, if you combined the top 7 causes of cancer in women together, it still is less kills less women than heart disease does. So this is a striking slide. If I had breast cancer on here by itself, it would be down around between Alzheimer's and diabetes, so that you can see this is a huge problem in women. Although the Komen Foundation does an excellent job of advertising the effects of breast cancer, we don't do quite as well with heart disease, even though this kills more women than breast cancer. There are many reasons for this disparity, and I'm just listing a few of them on this particular slide. We know women are generally 7 to 10 years older than men when they present with their initial myocardial infarction or heart attack. Since women are older and they're usually over the age of 65, most of them have either had natural menopause, and many women have also experienced surgical menopause. One of the very important factors is that women tend to have more, and not only the number of comorbid conditions at the time of diagnosis, but substantial comorbid conditions such as diabetes, obesity, and women tend to have more systolic hypertension than men do. Also, lack of symptom recognition of coronary heart disease and myocardial infarction in women continues to contribute to this disparity. And that's where my research has focused, and I'll be spending some time on that in a few minutes. One of the ways that we go about trying to decrease mortality rates is to raise awareness. And we have been trying over a period of years to increase women's awareness about heart disease as the #1 cause of death in women. And you can see that we've been doing this since about 1997, and Lori Mosca has led this initiative, and we have collected this over numerous years. And we have shown some substantial increases in recognition, primarily in white women. And you can see, unfortunately, that it peaked at the year 2006. Now we are beginning to see a decline in recognition of heart disease as the #1 cause of death. But we have never made substantial gains in our Black and Hispanic women, and those women are even more at risk for developing heart disease and having higher mortality rates than white women. So it's exceedingly important that we continue to work on getting the message out to women that they are prone to develop heart disease, need to be aware of it, and need to be looking for signs and symptoms and risk factors in themselves and in their friends and family members. Now, once a woman has a heart attack, women tend to do worse than men do, and that's one of the reasons we have higher mortality rates as women age. After MI, if women are greater than 45 years of age, as compared to men in the same age groups, 26% versus 19% are more likely to die within the first year after having a heart attack. If women are under age 50 at the time of the MI, they are twice as likely as men to die in that year in the same age group as men. And after MI, 46% of women, as compared to only 22% of men, are disabled within 6 years after their first MI. So that's over twice the number are disabled as compared to men. And this is very important because women tend to be single head of household, oftentimes are raising not only their children perhaps, but their grandchildren. So this has significant impact economically, besides quality of life issues, etc. The impact of women has other differences also. Women tend to have more symptoms. So you'd think that it would be easier to recognize since they have more symptoms, but indeed that is not the case. They also have more physical limitations, which leads to the disability that I referred to earlier. Especially young women and those in midlife tend to have more physical limitations. Women also have less obstructive cardiovascular disease when they are referred. So if women can present and a physician suspects that they might have heart disease and they refer them for angiography or to have a coronary angiography, they have about a 50% chance of not having anything wrong with their coronary arteries. And it has to do with that they have less obstructive cardiovascular disease. Women have more microvascular disease, and this does not tend to show up on cardiac cath until this is a very advanced stage. They also have lower levels of biomarkers of cardiac necrosis. So if women come into an emergency department and they're having an evolving myocardial infarction, their enzymes won't elevate as quickly as men. And when they do elevate, they tend not to elevate as high as men. So a lot of times, since they elevate later, they tend to get sent home from the emergency department when indeed they're actually having an evolving myocardial infarction, but their EKG has not shown any changes yet, and they don't have any biomarker changes yet. Now, there are many reasons why biomarkers are different, why the microvascular disease is different, and it's because we have actual physiologic differences, sex differences between men and women. And after the reproductive system, the cardiovascular system has the most sex-based differences. And we tend not to even think about that. We tend to think, well, reproductive system, that's the main difference between men and women. And indeed, there are many differences in the cardiovascular system. And these are just a couple that I've listed on this slide. Women obviously have smaller coronary arteries, so it makes it harder to stent. Because our stents were developed for men originally, and we have a difficult time putting them in these small arteries. Women have more breast tissue, so that makes it harder for our diagnostic tests to have results, positive results that are correct. We also have differences in hematocrit and obviously estrogen levels. Women have more mitral valve prolapse. They have more left ventricular hypertrophy, higher myocardial blood flow. And these are just some of the physiologic sex differences that we see in the cardiovascular system. Now, even if we have these women recognize that they have symptoms going on, that something's different in their bodies, they may or may not suspect that it might be heart disease, women tend to sit at home and try to figure out what's wrong with them. And this delay in seeking treatment is detrimental to women's outcomes and contributes to the higher mortality rates. And we know the profile of people that tend to sit home the longest. They're usually older age, female, they're usually African American race, oftentimes lower socioeconomic status, and this relates to not having insurance. And since we're in the Affordable Care Act era now, we may begin to see some changes with the lower socioeconomic status not being as highly correlated. They also tend to not be aware of what cardiovascular symptoms are typical in women, and they oftentimes have a history of comorbidities, and these comorbidities may have some of the similar symptoms, and so they think there's just something going on with the other processes, diabetes or something like that they may have, so they attribute those symptoms to that. The other issue that goes on with this delay in seeking treatment is women are oftentimes caregivers, especially in the older age, and they don't have anybody else to call in immediately to come and sit with the person that they may be the caregiver for. And they tend to get all of that arranged before they seek any treatment for themselves. Now, the consequences of delay in seeking treatment, first of all, treatment is extremely time dependent. If we don't get there within 70 minutes of symptom onset, there's a 7-fold increase in mortality. So it is extremely important that women recognize these symptoms and seek treatment immediately. And we know over 250,000 die annually before reaching the hospital. And the average delay is 2 to 4 hours, and you can see that's well outside of the 70 minutes of time. And we know also from studies that minority populations tend to delay seeking longer. Now, lack of symptom identification is a huge problem for women, and that's almost all of my research has focused on symptom identification in women. And we have tended to suspect and to indeed look for the same symptoms in women as we do in men, because we did not realize the difference in the sex differences in the cardiovascular system that I addressed earlier. So we thought women would present very similar to men. And in fact, that is not the case. Some women do, but a lot of women do not report chest pain as a chief symptom. And we have been taught in our nursing school, in medical school, in textbooks, people have read this, we see it on TV, we see it in movies, that if someone's having a heart attack, they clutch their chest and they collapse to the floor, indicating that this severe chest pain is the cardinal symptom of heart disease, and it is not always that in women. We know that if chest pain is not a chief symptom, and this is true either in men or women, but particularly in women, they are more likely to be misdiagnosed. They are twice as likely to die after misdiagnosis because they didn't get adequate treatment as compared to those who are diagnosed with an MI. And women less than 55 years of age or minorities with shortness of breath as a chief complaint are the most misdiagnosed patients that present that are actually having an MI, but we misdiagnose them. And this shortness of breath, as you will see later, is oftentimes a presenting symptom for women. However, little is really known about women's symptoms or possible racial differences in those symptoms, and that's why that has led to a lot of my research. So we need to address factors that shape women's symptom presentation and to identify these symptoms. So why do women's risks remain high? We are now advertising that this is a #1 disease in women, killer in women. We have know that we're getting better treatments. We know that there are these sex differences, but we still know that women's risks are extremely high. And I really contribute a large portion of it to failure to discuss risk factor modification with women with every healthcare encounter, whether it's in a clinic, whether it's in a hospital, whether they call in, whether they come in for a flu vaccine, anything. We should be talking with them about risk factor modification. And we also have inadequate education related to gender and racial differences. We still have a lot of healthcare providers that have been practicing for a long number of years, and perhaps are not as up to date with the research that's been going on with women and heart disease. And so they are not quite as aware. We also know that there is bias present, and how much is due to lack of education and how much is actual bias remains to be determined. But we know that there is some there with studies that have had men and women in vignettes coming in with the same symptoms and having healthcare providers pick treatments and diagnoses, and we've had numerous studies that have shown that they will treat the men differently than they do the women. They tend to treat the men for MI. They tend to treat the women with other diseases and send them home. So we know there's some bias present. Now, risk factors are the most important way. If we can prevent having an MI in women, we can limit, obviously, the length of time that they might be disabled. We could perhaps prevent them from ever having an MI. So we have to do these risk factor modifications and move this to primary prevention. And here are the modifiable risk factors for coronary heart disease in women in the United States. And you can see we've broken this down by year so that you can begin to see the trends. So the blue is from 2006 to 8, the red is from 9 to 11, and the white shows in 2013. And I'm very interested to hear that you've had a session like this on smoking cessation, and you can see that we have a decrease in smoking rates, which is so important because it is the #1 modifiable risk factor in women, and smoking in women is twice as deadly as it is in men. So it is very, very important that we offer and talk with women, offer means to help them with smoking cessation, and talk to them about the significant risk that smoking imparts to them. Also, you can see, unfortunately, that the obesity continues at a very high rate. We also have inactivity, which continues to increase. We also have high blood pressure, which remains very high. We haven't had significant change in that over the years. And eating a proper number of fruits and vegetables has shown a little bit of an increase, but we're not back as high as we were in 2006 to 2008. So continue to have these risk factors. Now, there are some other risk factors that I want to spend some time talking to you about, if I can get this to switch. There we go. I wanted to show you about obesity trends. This is just from 2011, so I just picked these years that we had these maps available because these maps show it so good. I mean, it's just such a visual representation. And if I went back even further, if I went back to 2005, we would have had no orange at all on this map. And then you begin to look at 2011, how we have oranges creeping in. In 2013, we now have reds creeping in. And if we went to 2015, we would have even more of the dark red. We are very obese and continuing to increase numbers in this country, and it is extremely detrimental to our health. And one of the most troubling statistics of all is that we are seeing these obesity rates in children and in our teens, which does not bode well for the American population as they age and developing further heart disease. I'm having such a time there. The heart disease risk factor effect in midlife women, we tend to think, well, if I just have one risk factor, I only have one time the risk. But in fact, in women, these risk factors portray more risk than just the number that they have. It's called the multiplier effect. And so if women have 2 risk factors, they have 4 times the risk of developing heart disease as a woman that doesn't have any risk factors. If they have 3 or more, which is not unusual to have obesity, hypertension, and no exercise, those 3 oftentimes go hand in hand, that those women incur 10 times the risk as someone that doesn't have a risk factor. So these risk factor modification principles that I'm talking about are very important. Now, some of the unusual, or I call them novel risk factors that are emerging for women, and we have more research that needs to be done on these, but I think there is enough to call this to your attention at this point. There is a substantial gender difference with women being more susceptible to adverse cardiac events due to short sleep. And women are more likely to have short sleep due to we're the people that usually get up with our sick children. We tend to work different shifts. Women tend to have more difficulty sleeping as they go into menopause. And so women are more prone to have this short sleep cycles. So women with less than 5 hours sleep per night are over 2 times more likely to have a fatal cardiovascular event than those that get greater than 7 hours of sleep per night on average. But there is no elevated risk in men with short sleep. We also have reduced sleep in women associated with incident hypertension, but not in men. So you can see that there are some cardiovascular effects related with sleep, and we need more research in this area. Also, women tend, especially single head of household women and our minority women, oftentimes live in poorer neighborhoods that are very close to freeways and highly trafficked areas. And we have excellent research that started over in Europe, and we are beginning to see more research done in this area about exposure to particulate matter. And that's where we see matter, this particulate matter from coal-fired power plants, from diesel engines, by the trucks, and it really increases our exposure. And so we know that the cardiovascular disease risks are increased with exposure to this particulate matter in this air pollution. And living close to these highly trafficked freeways has been linked to increases in coronary artery calcification. And we know that that in itself is a potent risk factor for developing myocardial infarction. And what happens is this particulate matter sets up a series of responses. It's like a culminating effect. One triggers another, which triggers another, and it sets up this inflammatory response and is dose dependent. So the more particulate matter, the more pollution you're exposed to, the more inflammatory response you're going to have. Also, we are well aware of oral contraceptives and the effect that it has on women. So we should be assessing women that are on oral contraceptives for other cardiovascular risk factors, especially if they're over the age of 35. And it's especially important if the women are smokers, have uncontrolled hypertension, or history of migraine headaches. And you can see the impact that contraceptives have on our lipid panel, and it also worsens glucose panel. Now, hormone replacement therapy, there's a lot of controversy about it. We have some studies that are indicating that you should not be on hormone replacement therapy. It does not have any prevention impact on developing cardiovascular disease, although there are some that say women who initiated hormone replacement therapy closer to the onset of menopause had a decreased risk of developing this than those who initiated it further from menopause. So we have more research to do in this area. So to make the diagnosis of CHD, we have to first identify risk factors, assess for prodromal symptoms, and implement primary and secondary prevention measures. Now I'm going to talk a little bit about my work and go over some of the symptoms with you. This work was supported by the National Institute of Nursing Research. And the purpose was to really compare ethnic differences in prodromal and acute symptoms in women that I recruited from 15 sites across the country. This was a retrospective study, meaning women had already had an MI 4 to 6 months, and this gave them time to recognize their symptoms. We also did a cognitive screen to make sure they could remember their symptoms appropriately. We administered an instrument that contains 33 prodromal and 37 acute symptoms, risk factors, and comorbidities. And I'm going to just talk about the prodromal symptoms today. There were 1,270 women who completed the study. You can see we had 43% Black and approximately equal number of white, but not as many Latina or Hispanic. They were all over the ages of 21 and indeed were post-myocardial infarction. White women were the oldest, the most educated, and had the highest income in the group. The 95% of these women reported at least one prodromal symptom, and the most frequently reported by 73% of the women was unusual fatigue. And this fatigue is unusual in that it can't be explained. They go to bed tired, they get up tired, and it interferes, in its most severe form, it interferes with their ability to conduct their activities of daily living. We did have significant ethnic differences in reporting 17 of the 33 prodromal symptoms. And we actually looked at the mean number of symptoms and the score, the intensity of it and the frequency of it. And you can see that the Black women had higher scores, meaning they had a greater number of symptoms and they had higher intensity and frequency of experiencing those symptoms than did Hispanic and white women. So what were these symptoms that they reported? As I said, you can see this unusual fatigue was the #1 symptom, and it was reported by overall 73% of them. And the colors indicate red is for Black women, the blue is Hispanic, and the green is for white women. If you see two like a dagger, and then the snowflake, if the two snowflakes means there was no significant difference. But if there's a snowflake and a dagger, that means there were significant statistical differences. But you can see that all of these reported these first 5 symptoms approximately in equal numbers, although there were significant differences in anxiety between our minority women and white women, and frequent indigestion. Also sleep disturbance, and then the shortness of breath. Other of the next 5 most frequently reported symptoms, and again there were statistically significant differences. Heart racing was a symptom, changes in vision. They had chest pain and or discomfort, and these women tended to describe this as discomfort. And this appeared as a frequent prodromal symptom when we combined 4 different locations of chest: high chest, middle chest, right chest, left chest. They also reported changes in thinking and decrease in appetite. We then wanted to know what women were reporting these particular symptoms, and so we looked at women in different clusters who reported these particular symptoms. Women in cluster 1, and there were by far the majority of women, the largest number were in cluster 1, and these women tended to be white women, and they tended to be older women. And women in cluster 2 were a little bit younger, about equal minority and white, and cluster 3 were primarily young women and minority women, and they reported the greatest number of symptoms. And this is just a percentage to show you the women that had a symptom in the prodromal phase, so that means before the heart attack, and then in the acute phase, that meant when they were actually experiencing the heart attack. So you can see women tended to have the same early warning prodromal symptom as they did with when they were actually having their heart attack. And since prodromal symptoms by definition mean these symptoms come and go, before they actually have their heart attack, these women tend to just sit at home and wait for these symptoms to go away as they had done in the past. And most women report these prodromal symptoms over a period of months before they actually have their heart attack. Now this is the cluster analysis, and this is when we looked about the women that reported and fell into these particular clusters. And this is what I was telling you about how these clusters collapsed. So in cluster 1, we had 552 women, and the symptom that had the greatest probability of occurring with these women were this unusual fatigue. But as we got into cluster 2 that had the next most women, you can see we began to have high probability of this unusual fatigue and sleep disturbance. And then by the time you get to cluster 3, we had the smallest number of women in that. But look at all the symptoms that they reported experiencing. And you can see why it might be difficult to diagnose them as heart disease because they have such a wide variety and number of symptoms. Next, we looked at the 10 characteristics of who were in these groups. And we looked at them according to age, race, body mass index, or obesity, essentially, personal history of heart disease, diabetes, and their smoking status. So this is what I was explaining earlier, that women in the first cluster that had the fewest symptoms tended to be older, they tended to be white, and they also tended to be have less diabetes, they had lower BMIs. Women in the cluster 3 that had the most symptoms were younger, more likely to be Black, they were more likely to be diabetics, they were more likely to be very overweight, and to be smokers. So our summary, the chest pain discomfort was not identified as a primary prodromal symptom. The unusual fatigue and shortness of breath were, and African American women less than 50 years of age were more likely to complain of frequent and intense symptoms compared to other women. So for clinical application for prevention, we need earlier and more aggressive measures to identify, control, and eliminate the risk factors. We certainly need more sex and gender-specific research to improve our evidence-based practice. We need to change our focus to prevention from treatment, and we need evidence-based to tailor education for women so that they will be able to recognize heart disease as their #1 killer. Lifestyle interventions, certainly we have to talk about cigarette smoking and talk to them about the effects of environmental tobacco smoke, including secondhand smoke. They must talk about increasing activities and physical activity. I got a Fitbit, which my husband and I are wearing, trying to get us to at least build up to 10,000 steps a day, which is the recommendation. And if we can just walk and get that, it will at least begin to help us with increasing activity. And certainly women who have an MI should be referred for cardiac rehabilitation. Specific dietary recommendations, you can see these are not new. These are just really eating in moderation and increasing fruits and vegetables, increasing fish, decreasing sugar, decreasing saturated fat, decreasing sodium. So these are very common recommendations, but these need to be enforced to women. And if we could just modify one risk factor, and 78% of all adults alive today are candidates for modification of at least one risk factor. And it's estimated that we could reduce by 63% the number of MIs just by smoking cessation alone. And we could save over 36 million deaths worldwide if we could at least modify one risk factor. And I'll be glad to answer any questions if we have time at this point.
Thanks, Dr. McSweeney. And we will remind you for everyone to go ahead and use the question and answer portion of on the webinar format on the right-hand side of your screen that you can type in your question. And Misty, if it's okay with you, we'll go ahead and unmute the lines for those of us that are on the phones today. And if you'd have any questions, we'll go ahead and ask for those now as well. Uh-oh, guess we should have warned everybody. All the lines are unmuted, so if your line is not currently muted, we ask that you do that to prevent the feedback. Oh, thank you.
I took that phone call.
Well, hearing no questions, we'll go ahead and turn everything over to Misty Kevich, who will talk about a few resources that are available to home health agencies. And we'll come back to questions in just a minute. And we'd like to thank Dr. McSweeney because there were quite a few points that you made that were very specific to home health agencies, whether you realized it or not. So this is an extremely timely and important information that you're presenting. So we'll go ahead and turn it over to Misty Kevich and come back for questions at the end. Misty?
Thank you. Well, first I would like to thank Dr. McSweeney. It was an excellent presentation and so many factors that affect the patients that those are on the call today that we do serve and are trying to make a difference. We have related resources to touch and help on a lot of the lifestyle modifications, and including not only diet and sodium reduction with the lifestyle modifications, but also smoking cessation. And they're included in our cardiovascular part 1 and part 2, as well as our focused best practice packages, blood pressure control and smoking cessation. We're very excited to, in the next couple months, you'll be seeing 3 patient videos, 2 patient videos, 1 clinician video that are related to smoking cessation. And we've had our previous HHCDR call, a smoking cessation call. I think that's probably one of the hardest areas for us to do in home health. Thus, that's why we put a lot of time and resources in trying to help home health agencies, clinicians to learn to interweave those resources. So those I highly recommend. The next slide. There is also using aspirin for primary prevention for cardiovascular health that is also included in the best practice part 1 that can be very tailored to the women. And the next slide, please. And then also we have lots of blood pressure control materials. This is just one sample. We have lots of different pieces that are included. There is one more video. Crystal had mentioned at the beginning that we are starting our video BPEPs that will start for April 1st. And the first one is, are you at risk for a heart attack and stroke? So it is created for the general population of all ethnic backgrounds, but it talks about the risk factors and what the signs and symptoms are. Although we do go into abnormal signs and symptoms. I think after listening today to the presentation, we're already, my colleagues and I are already back and forth working on what we can do to continue to advance that knowledge from her studies. But it really is essential to get patients to be aware of their signs and symptoms. So do look for that. Plus, there are some puzzles and word finds that go along with that to help reinforce that education. So look for more to help supplement that. And I'm going to turn it back over to you, Cindy.
Thank you, Misty. And we do have a few questions coming in, so we'll go ahead and ask these of Dr. McSweeney, and we'll get through as many as we can. Let's start with, what is the rationale for women still outliving men by 10 years? Do you have anything for that?
I think I don't have anything cardiovascular-wise, let me put it that way. But I think once women tend to realize that they do have risk factors and they do try their best to be able to take care of themselves. And I think women have outlived men for a long period of time, so I don't know that there's anything particularly new to add to that.
No, but I agree with that question. I was wondering, as you were talking about some of the differences that I hadn't even considered when it came to cardiovascular care in women, something as simple as the stent size and the difference in the CPAs. So we'll go ahead and move to the next one. Thank you for that. How does familial hyperlipidemia fall in the risk factors for women?
It's a potent risk factor. I don't mention that because it only affects a small number of people, but it would affect men and women and should be treated, obviously, as aggressively as possible.
Thank you for that. We have another question that is, what techniques are most effective for lifestyle modification for women related to mitigating to risk factors in women?
One of the things that I found, I've done a lot of qualitative interviews with women and talked with them about making behavior changes. And what I've found has been most successful, especially if they've already had a heart attack, is to ask them what they think caused their heart attack. And if you can get them to at least identify one of the main risk factors as what they perceive as what caused their heart attack, they have a lot of success changing that. We tend to try to get them to change everything at one time because we see it from a healthcare perspective. Gosh, they're overweight, they smoke, they, all of these things. And if you ever tried to go on just a diet or to try to just increase your activity, it's difficult to do one thing, but if we try to get them to do everything at the same time, they tend to do that, they fall off the wagon, and then they just do not even try again. So I try to have them pick one thing that they thought contributed most significantly, or if we were looking at primary prevention, we could ask them what they thought was their biggest risk factor and then help them figure out how to modify that one risk factor. For instance, I had a woman one time that had an MI, and she thought the #1 cause of her heart attack was that she was a smoker. And she worked diligently to quit smoking, and this was before we had so many aids out. And she did indeed quit smoking, and she went back to see her cardiologist like 2 months after her heart attack, and she had not had a cigarette, and she was so proud of herself. And she had gained weight, and she got yelled at because she gained weight, and never really praised because she quit smoking. And so I think we really need to try to tailor this to where they are, and when they're successful with one, give them a lot of praise and let them pick if they think there is another risk factor that they could begin to modify after they've had success with one. I think this is so important, and not to try to get them to do everything at the same time.
That is fantastic advice, and it's something with self-management that in home health we are continuing, and healthcare in general, to allow the patients to direct their healthcare. Thank you so much for that. As for everyone on the line today, for additional questions as you have them, please contact us at hhqi@wvmi.org, and we'll be happy to try to get your answers and to share them with everyone. But as we're concluding today's webinar, I would like to again thank Dr. McSweeney very much for her time, as I'm sure we all have appreciated, if not put most of us in a bit of a panic mode. But we want to thank you for sharing not only your research, but also bringing the evidence to us in an easy-to-understand format. I'd like to remind everybody that the next CardioLand webinar will be on April 16th. And at that time, we'll be covering the role of the therapist, having 2 physical therapists presenting not only the scope of practice of physical therapy, but how the role of the therapist can impact the cardiovascular care in the home health system. So we'd like to invite all of you, if you have not already registered, to go ahead and make sure you are registered for the CardioLand so that you will receive that invitation. And with that, we would like to close today and say thank you to all of you for taking the time to share an hour with us this afternoon. Have a good day.